morning. My topic for today is Furcation involvement. So, moving on to the definition of furcation. Furcation is an area of complex anatomic morphology that may be difficult or impossible to deprive by routine periodontal instrumentation. And the furcation invasion is the pathologic resorption of bone in the anatomic area of multi-rooted tooth where the roots diverge. Moving on to the significance of furcation. Furcation can mean different things to the patient and clinician. First of all, for the patient, routine home care methods may not keep the furcation area free of plaque. And for the clinician, furcation area may be difficult or impossible to deprive by routine periodontal instrumentation. Also, the teeth which have furcation, it means that they are potentially less favorable prognosis when compared to the other teeth, thus presenting both diagnostic and therapeutic dilemmas. So we have to get used to certain terminologies before going on to further treatment planning or diagnosis of furcation. This is mainly related to the tooth as well as the root. So first of all, what is the root complex? It is a portion of the tooth that is located apical to the CED, as you can see in this. Then the root trunk is the undivided region of the root. So the root complex has root trunk and root core. Root trunk is the undivided region of the root. The root core is the divided region of the root complex. And the height of the root trunk is basically the distance between CED and the separation line between two root cores. The furcated region is made up of these two root cones together. Furcation entrance is basically the transitional area between the divided and undivided part of the root. And the furcation fornix makes up the roof of the furcation. So these are the basic terminologies we have to get used to. Moving on to the etiological factors that are involved in furcation. So the primary etiological factor, as always, is bacterial plaque. There are some local anatomic factors, anatomy of bony lesions, and some other dental findings. So what are these local anatomic factors? These mainly comprise the root trunk length, the root length, interradicular dimension, furcation anatomy, the presence or absence of cervical enamel projection. And the local anatomic factors are basically again the root part, the root trunk length, and root top. So basically, once the furcation is exposed, teeth with short root trunks are more accessible to surgical procedures and maintenance procedures. That means like a short trunk means less attachment has to be lost before furcation involvement, accessible to treatment more than tooth with long trunk. And long trunks similarly, more attachment has to be less accessible to treatment than flat trunk. And when it comes to root length, once the furcation is exposed, teeth with long roots and moderate to short root trunks are readily treated because there is sufficient attachment to meet functional demands. And moving on to root form, curvature and fluting may increase the potential for root perforation during endotherapy, vertical root fracture during post-placement, and mesial root of most mandibular first and second molars. Local anatomic factors are not complete just with the above factors. There's also the interradicular dimensions and the anatomy of furcation that have to be considered. So in interradicular dimensions, basically the degree of separation. The separation is narrow, the roots are fused, roots are close to each other, and when so close approximation of fused roots can prevent adequate instrumentation during scaling, root veiling, and surgery. So if the roots are more wider or widely separated, they are more accessible to treatment. So, and also the anatomy of furcation, presence of bifurcational ridges, concavity in the dome, and possible accessory canals complicates all the periodontal treatment planning procedures and the maintenance procedures that we plan. And cervical enamel projection. Cervical enamel projection prevalence is highest for mandibular and maxillary second molar. It can affect plaque removal and should be removed to facilitate maintenance. And according to Masters and Hodgkins, it has been classified into grade 1, grade 2, and grade 3 Grade 1, the enamel projections extend from CEJ towards the furcation involvement, but it does not reach the furcation. Grade 2, it approaches the entrance to the furcation, but not horizontally. Grade 3 extends horizontally into the furcation. Other factors include anatomy of bony lesions, and we have to see whether the pattern of the attachment loss can be horizontal or vertical. And some other dental findings like dental and periodontal condition of adjacent teeth are also taken into factor when we are considering the etiological factors involved in furcation. Then another important part when diagnosing and managing furcation are the furcation classification indices. These are based on the horizontal measurement of attachment loss in the furcation, combination of horizontal and vertical measurements, and a combination of these findings with the localized configuration of the bony deformity. So Glickman's classification is the most important classification when diagnosing furcation defects. So these include, first it has been classified into 4, grade 1, grade 2, grade 3, and grade 4. Grade 1 is the incipient or early stage, the early lesion. The pocket is suprabony, primarily affects the soft tissue. There is an increase in foving depth seen, but radiographic changes are not found. Grade 2 is the curl defect lesion with a definite horizontal component. It can affect one or more furcations of the same tooth. Multiple defects do not communicate with each other. Vertical bone loss may be present and which may or may not be depicted in radiographs. However, the presence of furcation arrow in radiographs indicates possible furcation involved. Grade 3 is through and through defect where the bone is not attached to the dome of the furcation and the opening may be filled with soft tissue. Radiographically, it appears as a radiolucent area in the crotch of the tooth. Grade 4 is the lesion in which the interradicular bone is completely destroyed. That is through and through lesion. Soft tissues have undergone recession, have receded apically. This furcation involvement is clinically visible and a tunnel will be seen between the roots and it's clearly visible in radiographs. So that is the Glickman's classification of furcation defects, grade 1, 2, 3, and 4. Some other classification indices are also there. Some other popular indices are Hambertol 1975, Turner and Fletcher has given classification 1984, Eastley and Drennan, etc. So we have basically deal with the introduction, the etiologic factors, and the classification indices. Moving on to how you will diagnose a furcation. This can be by probing, by bone sounding or transgingival probing, routine radiographic assessment, and CBC. So probing is basically using a Weaver's probe, which has color-coded markings. Bone sounding, we can go for by giving local anesthesia to the area, and then we can use a probe to practically go deeper into the area to analyze the anatomy of the furcation defect. Routine radiographic assessment may be by IUP or OPG, and CBCT can also help in identifying the anatomy and how it looks, the furcation defect looks. And how much bone loss has been, the amount exactly can be mapped in CBC. That's how you basically diagnose furcation defects. And moving on to the last part is the treatment. How do you manage furcation defects? So what are the objectives of furcation therapy? What we need to know. First, it is to facilitate maintenance, then prevent further attachment loss and obliterate the furcation defects as a periodontal maintenance problem. So how you will choose this particular management technique, it varies with what is the classification of the furcation involvement, how much bone has been lost, and other various anatomic factors that are involved. So according to this, the treatment can be classified into non-surgical therapy as well as surgical therapy. So non-surgical therapy, basically we go for oral hygiene procedures, that is professional mechanical plaque removal and subgingival debridement, as well as we give basic chemotherapeutic agents, local and systemic antimicrobial therapy. Surgical therapy can be resective as well as regenerative. This can be comprised of restorative management, furcation plasty, tunneling, open flap debridement and root conditioning, root resection and hemisection, regenerative therapy, as well as the last stage is extraction. When nothing else works, we have to extract the teeth. So according to this, there has been some classification of furcation defects, that is therapeutic classification, according to how we will manage these furcation defects. Grade 1 is early defects. So the incipient or early defects are amenable to conservative periodontal therapy. So basically we start with oral hygiene, scaling, root debridement, because the pocket is suprabony and does not enter the furcation. Like overhanging margins of restorations may be eliminated. Then odontoplasty can be carried out to eliminate CEPs, etc. Basically, the periodontal health is restored by resolution of inflammation. Grade 2 defect means it's a more active defect. Therapy is more complicated once the horizontal component of the furcation has developed. So, shallow horizontal involvement without significant vertical bone loss responds to localized flap procedures with odontoplasty and osteoplasty. So, this is basically the furcation plasty part. Then isolated deep class 2 furcations may respond to flap procedures with odontoplasty and osteoplasty again. This reduces the dome of the furcation and alters gingival contour to facilitate the flap removal easily for the patient. So basic odontoplasty as well as osteoplasty. Then there is the we are coming to open debridement, open flap debridement and apically positioned flap. So this is basically done in grade 2 defects when we have to go deepen, clean the area, remove all the granulation and the calculus that is adhering to the defect. So we go for open flap debridement and we apically position the flap so that the patient can keep the area free. Tunneling, the main advantage is the avoidance of prosthetic reconstruction and for mandibular molars and endodontic therapy. So the furcation entrance dimension is wide enough and coronally located to allow for an easy utilization of cleaning devices. That is, both the patient as well as clinician can clean the area. So this tunneling is mainly done in the mandibular first molar region. Then grade 2 to 3 advanced defects. So basically we go for the other kind of, definitely mostly we have to go for the surgical therapy for these advanced defects. So both, this involves both the horizontal component and the deep vertical component. And thus non-surgical treatment is usually ineffective. So periodontal surgery, endodontic therapy and restoration of the tooth will be required to retain the tooth. Regeneration is usually done on furcation defects with deep 2-walled or 3-walled components. We have to use open flap debridement with or without membranes and bone graft to cover the defects. So this is one such case where open flap debridement is done. We can see that graft and membrane is placed in the area, and the pre-op and post-op radiographs can also be seen with good coverage of the good bone apposition in the furcation area. Guided tissue regeneration being carried out similarly. To cover the furcation area, membrane has also been placed. So after all the open flap debridement, regeneration, everything, still there are some defects that are not amenable to all these therapies. In such cases, we have to move on to resective therapy. This can be divided into root resection or hemisection. The root resection is indicated in multi-rooted teeth with grade 2 to 3 furcation involvement. It may be performed on vital or endodontically treated teeth. Indication, teeth that are of critical importance to the overall dental treatment. Teeth that have sufficient attachment remaining for function, and teeth in patients with good oral hygiene and low caries activity. So the question arises, which root to remove? First, we have to consider the root that will eliminate the furcation and allow the production of a maintainable architecture, and remove the root with the greatest amount of bone and attachment loss. We can't do anything else to keep the teeth intact. Such roots we have to remove. Also, the root that best contributes to elimination of periodontal problems are adjacent teeth also, and which has the greatest number of anatomic problems, and the root that least complicates future periodontal maintenance. So these are the roots that we take into consideration for root resection. So the procedure as such, we have to give local anesthesia. Full thickness mucoperiosteal flap is elevated, so we can see the area. There is adequate visualization and instrumentation. And after debridement, the root is resected with the exposure of the furcation on the root to be removed. And the cut is directed from just apical to the contact point of the tooth, through the tooth to the facial and distal orifice of the furcation. It is made with a high-speed surgical length fissure or cross-cut fissure carbide burr. If a vital root resection is to be performed, a more horizontal cut through the root is advisable. Oblique cut exposes a large surface area of radicular pulse or dental pulse chamber. So it can lead to post-op pain and complicate endodontic therapy. That is why we go for the horizontal cut, which has less post-op complications. So the remaining root stem is removed by odontoplasty. After sectioning, the root is elevated from its socket, and care should be taken not to traumatize the bone. So this is a pictorial representation of root resection. Similarly, a clinical case where root resection is performed. And another procedure in resection is hemisection. This is basically splitting a two-rooted tooth into two separate portions. So this process has been called as bicuspidization or separation, because it changes the molar into two separate tooths. It's most likely performed on mandibular molars with buccal or lingual class 2 or class 3 furcation involved. After sectioning, one or both the roots can be retained. So the interradicular dimension between the two roots, that is an important factor in hemisection. As opposed to root resection where a horizontal cut is given, so hemisection, a vertically oriented cut is made facial-lingually through the buccal and lingual developing roots of the teeth, through the pulse chamber and through the furcation. Retention of both molar roots can complicate the restoration of the tooth, since it is difficult to provide an adequate embrasure between the two roots for effective oral hygiene maintenance. So orthodontic treatments for the separation of roots may be needed to allow restoration with adequate embrasure form. So this is a procedure. This is a clinical case where hemisection has been performed, and it is divided into two different teeth as such, and restoration, prosthetic rehabilitation has been done. Another case, and the last part is when none of these things work, we have no other choice but to go for extraction. This is in patients with grade 3 and 4 furcation defects and advanced bone loss. So as I said, we cannot perform plaque control. There's a high level of release activity. A maintenance program cannot be performed. Those have socioeconomic factors that may preclude more complex therapy. In such cases, we go for extraction of teeth. So these are the basic treatment options as I've discussed for multi-rooted teeth with furcation involvement. And of course, after extraction, we have to consider prosthetic treatment options, rehabilitation options. Implants can be considered, or we can even go for fixed partial dentures, anything, but implants are the best treatment option. So prognosis. So the key to long-term success of in furcation management appears to be a thorough diagnosis, selection of patients with good oral hygiene, careful surgical and respirator management, etc. So to conclude, furcation is the area located between individual root cones, bifurcations as well as trifurcations. So effective management is the effective diagnosis and management is key to managing all these things. So we have to be able to diagnose the furcation involvement correctly, classify it correctly, so that we can advise the patient as well as formulate an adequate treatment plan. So these are some previously asked questions for furcation involvement, both essays and short notes. Thanks.